My name is Quang Nguyen. I'm a co-chairman for the Division of Ophthalmology at Scripps Clinic, as well as the glaucoma director at Scripps Clinic. We deal with a lot of complicated glaucoma cases requiring trabeculectomies or tube shunts. Been in practice for about almost 9 years before the inception of Trabectome. I saw the need for a new procedure to lower the IOP, as well as the ability to minimize a lot of surgical damage to the tissue. The truth of the matter is that trabeculectomy, while it offers low IOP, it carries a lot of liabilities with it. Trabectome has been a great option for my patients. Having more options in the treatment of glaucoma is better for the physician, but ultimately patients will benefit from these newer procedures. I was attracted to Trabectome because of the fact that you're not manipulating the conjunctiva. It's done through a clear Quang incision, and so you save the conjunctiva for future operation if needed. And that was my attraction. I was convinced that Trabectome has a real role in my treatment of glaucoma in my practice. I'm looking at patients to reduce the number of medications, avoiding adding more medications in the early to in the mild to moderate, or even the ocular hypertension patients. And so there's a huge range of patients that Trabectome can fill the gap. And I think the challenge we have in our glaucoma surgery is that there exists a gap between conservative treatment, that's including medications and laser, and then we escalate to a more aggressive surgery. And so Trabectome fills that gap nicely. Just like any procedure, patient selection is key. So again, the ocular hypertensive, the early to mild glaucoma, instead of adding more medications, we can actually reduce the medications or actually take away from medications to a Trabectome. And so those are the kind of patients that are really can benefit from this procedure. Some patients are very aggressive, they want something done and stay off medication, and I think clearly Trabectome is indicated for those patients. And the patients are conservative, they want to try medication first. I have that discussion with the patient, and let the patient help me decide what's the next step. In my mind, would I having the same conversation with this patient? It was my mom sitting across the chair. And I think that, to me, has been my approach. I treat my patients like my family, and in terms of deciding to do surgeries or no surgeries, that's the kind of thing that goes through my head when I have patients, discuss patients with surgical options. I think Trabectome has been a great option for my patients in my practice. The fact that its success continues many, many years and many more surgeons are using this procedure is a testimony of how well this procedure is and how well it fits into their practice. I'm pretty confident that Trabectome will continue to play a major role in the treatment of glaucoma in many years to come. So a patient actually from Hong Kong was desperate to have, she had failed several trabeculectomies and her glaucoma surgeon in Hong Kong was considering a tube shunt. I know this glaucoma specialist in Hong Kong very well. He communicated with me and we talked about the possibility of Trabectome. And she's a relatively young patient in her late 30s, and she did not want a tube shunt. And so we talked and I communicated with her. She actually flew out from Hong Kong to San Diego for me to perform the surgery. And Trabectome was very successful. Procedure was straightforward, and she has maintained a very good control for many years since then, without the needing of having more intervention at this time.